add to my surgery over the last 10 years and what robotics might add in the future. So this is a combination of two objectives. So I think we all, independent whether we use the technology or not, we have the same goals. Leg alignment should be within the 3 degrees, whether they are mechanical or kinematic or whatever, but 3 degrees. Joint stability in extension, flexion and mid-range. And you want to create the physiological anatomy, joint kinematics, and in the end you want to have patient satisfaction, which is quite difficult to get. Even in the scenario when you have maybe successfully achieved all the other four goals. And it comes to the question, how good are we really in reaching all those goals? And here in India, maybe I should have picked another picture, but in Europe, football is quite popular here, might be cricket. So, there is some data on that. And if we look at X-rays, not only on coronal X-rays, also on lateral views, around 80%, yes, it's a surgical technique, and definitely it is part of the success. Also, technology might help us to be more successful. Standardization, we have the two we discussed over the last decades, measured resection, gap balanced, and we know the advantages and disadvantages. But to be honest, 75 to 95. Not only in Europe, also in India. The other techniques like patient-specific instruments, all the conventional techniques, is the technique number one. So PSI mechanically, anatomically, or kinematically. A lot of chances you have, but also a lot of chances to do it wrong. So if you voluntarily want to undercorrect your tibia, so you don't want to make a 0 cut, you want to make an 87 cut, your chance to fail is around 40%. And on the valgus side, the chance is around 20%. So when it comes to all those modern alignment techniques, without navigation, you have no chance to do that. So you have to use CAS for that. Otherwise, again, with good intentions, but bad results. So I think coronal alignment, that's clear. What about the sagittal bony anatomy? So tibia slope, femoral size, component size, anterior posterior offset, very important parameters, and also the component flexion. And all those play together with our flexion gap and balance and stability in flexion. And if you look at the different blocks you have, your AP cutting block, that is important for your sagittal sizing and the anterior and posterior offset. The distal cutting block is important for your flexion and extension of the femoral component and the varus valgus position of that. If you place them in a bit different position, and that depends on your intramedullary rod, and you have no control about that. Whether you place that intramedullary rod really parallel to your femoral shaft, or you place it in 2 or 3 degrees of flexion, or maybe in hyperextension. And it's very much determined by your entry point and by your specific anatomy. With that, undersize or upsize your femur, and that is leading to a lot of problems. I think that one I can skip. So we have looked at our knees from the sagittal anatomy, and we analyzed that they were all navigated knees, gap balance technique. Then we looked at the X-rays in the lateral view, and you see in the coronal alignment, we're really happy, 97% within the 3 degrees. But when it comes to sagittal anatomy, very important part. And then you're back to the discussion, measured resection, every knee in 3 degrees of external rotation. and the epicondylar axis and your posterior condyles are the landmarks, or gap balance technique. Equal extension and flexion gaps and equal medial and lateral gap sizes. So when it comes to measured resection, I just want to ask you that simple question. What is the correct rotation? And if you then look into the literature, and then you see a huge inter-individual anatomical variability. So the relation between, that's my consequence. It's very absolute, but that's my consequence, okay? So the problem with that technique is I have to do my releases very early. If I do that too late, my femoral rotation will be wrong. So balancing must be performed very early. The navigation planning of a femoral component. You're aware of all the parameters. I try to guide you a bit. Here are the gaps. So in the end, you want to have 4 equal numbers. That's what most of us want to have. If you want to have a larger flexion gap, okay, you can do that. But most of us want equal numbers here, equal numbers there. And here now it's a mix of measured resection and gap balance. Here you see how much you resect distally, so that's the change in the joint line. That's not the millimeters, but you can chip that one here, and then you see 8 millimeters, 9 millimeters, or maybe whatever you think is right. And the same is here. You see your resection on the posterior condyles, medial and lateral one. You see how much you flex that, and you see the external rotation of that femur. That needed 2 degrees of external rotation to balance my flexion. Okay, so you're always aware of what you do, and I think that's the only method that shows you the gap and the amount of resection during surgery. That's also a big difference to the patient-specific instruments. The patient-specific instruments, you plan everything in advance with the joint, and especially in flexion, everything with one of those 3 spaces inside, and you see in that situation you have 4 degrees of external rotation, and you put in the same space at a second time. You see what happened now, it's 1.5 degrees internal rotation. So between the same spaces, 2 measurements, you have 5 degrees difference for rotation. A nightmare. So why should I navigate my knees? Everything is wrong. So we had that problem with the old navigation systems. Nowadays, luckily that is solved. Now you do, like you do it clinically, you do your stress tests for MCL and LCL in extension, in mid-range and in flexion. And simultaneously you see on your screen again how much the knee is opening up. And you do it again and again, and you really stress the ligaments to the limits. And you see, I again stretch it here, the lateral one in flexion to the limit, and now it's open to 13.5. So that's dynamic data. It's not static data like it has been before for the last decade. And I think that's a huge difference. We have seen that before, but it's really important. I just want to show you. Here you see the millimeters you resect, okay? Distal resection, posterior resection. And then when you flex the knee, how that influences the resections. When you change the rotation, how that changes the difference here. So you really fine-tune your knees by 0.5 millimeter here, a degree there, and whatever. So that's the kind of precision we hadn't before. Does that now lead to better results? That's the long, ongoing question. And yes, it is, but it's the combination of the gap balance technique with CAS that is leading to the better results. And there are a lot of papers now coming out, and I think the most important one is the Australian arthroplasty register. If you look at that arthroplasty register over the last 3 years, every single year you see that the revision rate in the young, very active patients with CAS is lower than without CAS. So now Australia is navigation country number 1. More than 40% of their knees are navigated. And the tendency is still growing. Is that a technique only for pros? To prove that, we have done one prospective study, one center in Spain, one in our place. There were 2 experienced TKA surgeons in Spain, one with navigation and one without. Just do the cuts. It's you have planned the cuts. And that's the same with the navigation. Still, you as a surgeon decide where you want to place the implant, not the robot will decide. And you are still needed for the soft tissue management. Which amount of release is needed for that one? Does the implant matter? Really matter? There's a lot of rumors always from the industry. I don't think it's a big difference. We tested that with navigation. There is some difference between a Sigma and an Attune. But from my side, I think the best implant in the wrong position is giving a bad result. So the most important thing is that you place your implant in the right position, and their technology can help you. And so to conclude that, I think the most important